Gastric bypass is a surgical procedure for weight loss usually performed laparoscopically. In this video, we will find out what it is, how does it work, who should have it, who shouldn't have it, what to expect in the recovery phase, what is the risk of short-term and long-term complications, and what are these complications, what are the results or outcomes, and how does it compare to its nearest rival, the gastric sleeve operation. To understand the gastric bypass operation, we need to know the basics of human digestion. Over here, you can see the food entering through the gullet into the stomach. The path of the food is outlined by the red arrow, then it enters the small bowel. Over here, it is met with bile coming down the liver over here, as well as the enzymes from the pancreas that are responsible for 90% of the digestion over here mixing with the food as it goes down the small bowel. And it is in the small bowel that digestion takes place. During the gastric bypass procedure, in the first phase, the stomach is divided and a small pouch, no more than 30 milliliters, is created. The great majority of the stomach, as outlined over here, is made redundant. At the same time, the small bowel is transected or divided. The small bowel that was divided is then advanced and is joined to the stomach pouch, and the other end is then rejoined to the small bowel. Hence, the food pathway outlined in brown enters the stomach. There's a bit of a hold up. The capacity is a lot less. It then enters the small bowel and it moves down. The other limb of the small bowel brings bile and pancreatic juice through this pathway shown in green, and then it meets with the food a lot further downstream than is the norm, and that is when the digestion starts. Hence, you can see that the stomach capacity has been drastically reduced. There is a bit of a hold up for the food to go through, and the amount of small bowel available for digestion is a lot shorter than was previously the case. There are two further cartoons denoting the bypass procedure. Over here you can see the gullet food entering the gullet and into the stomach pouch, and then entering the small bowel, going through that further downstream, meeting with the other component of the small bowel that brings down bile and pancreatic juice for digestion to take place. This limb of the small bowel that brings the part of the small bowel that brings down pancreatic juice and bile is called the biliopancreatic limb, and in general this is between 50 to 150 centimeters in length. The combined length of these two limbs is 200 centimeters, followed by what is called the common channel, where digestion may take place. However, the surface area available, as I previously described, is a lot shorter. So the mechanism by which this procedure works, threefold. Restrictive, because the size of the stomach is a lot smaller. Malabsorptive, because a large component of the small bowel does not take part in digestion. And endocrine, because it affects ghrelin and GLP-1, as well as some other chemicals that have direct effect on appetite, small bowel transition, and insulin. All patients who are considering having a gastric bypass operation ideally should be assessed by a multidisciplinary team that includes physicians, surgeons, psychologists, dietitians, and members of other allied specialties. In general, patients are offered multimodality treatment for at least a 3 to 6 month period before considering surgery. So who are the candidates? Those with a BMI of greater than 40, that's body mass index, calculated by dividing the weight in kilograms by height in meters squared, or those with a body mass index of 35 to 40 with an additional risk factor of obesity, of which there are many, specifically type 2 diabetes, cardiac, sleep apnea, arthritis, pulmonary related, etc. Or those with a lower BMI of 30 to 35 in whom type 2 diabetes is uncontrolled, or patients suffered with metabolic syndrome. So who should not have surgery such as gastric bypass are patients with psychiatric disorders, including eating disorders, those who are too high an anesthetic risk to undergo surgery, those with coagulation disorders, and those who've had previous gastric surgery, which make it technically not possible to consider a gastric bypass operation. What to expect in the recovery phase? As these operations are performed by keyhole, the recovery is expected to be quick. Patients are provided pain relief, control of nausea. They are encouraged aggressively to mobilize soon after the operation. Venous thromboembolism, that is a clot in the leg, is actively protected against by giving medication. Chest physiotherapy and coughing out the sputum is performed for most patients very early on to prevent a chest infection. Patients with sleep apnea are encouraged to use their CPAP machines even from day 1 onwards. There is some variation in practice. However, clear fluids are started soon after the procedure and aiming to commence a liquid diet by day 2. The liquid diet has a protein component, and the aim is to get at least 60 grams of of protein soon after the operation, continuing the liquid diet until about 2 weeks when patients are generally seen in the outpatients, and from here on a pureed diet may be commenced. Upon discharge, patients are given pain relief. However, non-steroidal anti-inflammatory medication are avoided to prevent the risk of ulcers forming. Patients are also given medication to reduce the acid content in the stomach by way of proton pump inhibitors that are usually continued for 1 to 3 months. Anti-nausea medication is also prescribed routinely to try and prevent severe heaving, which rarely is damaging to the newly formed surgical joints. It is important to commence nutrients soon after the operation, and other than caloric content, patients are advised to take multivitamins, iron and calcium supplements because large parts of the small bowel is now bypassed, and hence it is important to take a balanced diet with all the vitamins and supplements to make up for this. Patients' general medication is usually commenced soon after. However, they are advised to take the medication in a liquid form for a variable period of time on after. The risks and complications include a risk of mortality that is around 1 in 1,000. This used to be around 2% in the years gone by, but it has improved significantly. Still, for patients aged over 65, this can be as high as 4%, so it's age related. Leak means the stomach or small bowel contents leaking out of the new joint that have been created. It's generally the small bowel to the stomach joint, very rarely the small bowel to the small bowel joint. It isn't that the leak has occurred, which may happen in 0 to 5% of the cases, but it has to be detected early and treated effectively to have a good outcome. Stromal stenosis means inability of the food to pass through the narrow passage as outlined over here. So the patients then are unable to tolerate food or liquids and tend to vomit them out. Marginal ulcer means an ulcer forming either on the stomach side of the new joint or on the small bowel. Gastrogastric fistula in general is the progression of an ulcer forming, then forms a corresponding ulcer in the stomach, causing the food to leak out from here into the bypass stomach. Dumping syndrome is a set of symptoms such as cramping, abdominal pain, diarrhea, flushing and sweating, generally associated with carbohydrates such as sugars being taken into the stomach and arriving in the small bowel. Low glucose may occur in patients. This is due to a rebound increase in the insulin levels as well as a reduction in the previous insulin sensitivity, giving rise to low blood sugar levels. The future risk of an internal hernia and a small bowel obstruction, as seen in this cartoon over here, where surgeons attempt to prevent this by putting sutures in all the little crevices that may happen. However, this cannot completely be controlled. And finally, a very small cohort of patients may find it very difficult to cope with the outcome of the operation, and hence the importance of having trained psychologists at hand deal with this situation sometimes can lead to alcoholism, low self-esteem, and attempted suicide. What outcomes can one expect following a gastric bypass? Most significant are weight loss and control of type 2 diabetes. Patients are able to maintain a sustained weight loss over a prolonged period of time so that they lose 70% of the excess weight that they carry at 5 years. The regain in weight may be due to one of several features, such as the stomach pouch in general getting bigger over time, or the orifice joining small bowel to the stomach stretching and getting bigger, thus allowing more food to go through, or the physiological adaptation of the body. 75 to 80% of patients with type 2 diabetes go into remission, with improvement of control for the rest. This is a significant milestone for most patients. Those with high lipid levels experience an improvement, nearly half of them sustaining this for 3 years. Those with obstructive sleep apnea, 2/3 are improved due to weight loss, and all other parameters related to obesity are improved with this, both cardiovascular, respiratory, bone and joint related, gynecological and others. Now comparing the gastric bypass with sleeve gastrectomy in the various domains. Patients with gastroesophageal reflux or those with bile acid reflux are best advised to have the Roux gastric bypass because this is much superior than sleeve gastrectomy, specifically in this group of patients. Initial control of type 2 diabetes is thought to be somewhat equal in Roux gastric bypass as well as sleeve gastrectomy. However, most experts believe that in the long term, the gastric bypass is a superior option. The same applies to weight loss over the long term, where initial weight loss is similar. However, over the long term, most experts edge the gastric bypass as a superior option. Complication rate is lower with the sleeve gastrectomy both in the short term and the long term. And patients who are awaiting a transplant, whether it's kidney, liver, lungs or heart, who require weight loss, then sleeve gastrectomy is perhaps a better option, as well as patients with advanced liver disease are more likely to benefit safely from a sleeve gastrectomy rather than the gastric bypass. This completes this brief video. If you have any comments, please do share.